Well, we also have with us today Dr. Nancy Loos. She is faculty at Azusa Pacific University. I think you all know we're in California. These are California academic institutions. And I was quite intrigued, and I'm sure you will be when you have a chance to read through the abstracts. But I love this, Dr. Loos, where it says central, if I can read it here from my eyeballs, central to achieving safety and quality is effective communication. Wow, that is so valuable, but we're thankful that you're here with us today.
So I'm just going to start by saying I was raised in the church, and I was raised singing and playing. I was in the choir. My mother was the director. I was the church pianist, and I knew all the songs, and I knew all the words. And my husband, his thing to me is, you know all the words to all the songs you've ever heard. He's going to put it on my tombstone. She knew all the words. But in 1995, when Dr. O'Rourke first came to my hospital, and she started talking about the words to the song of nursing, I realized I didn't know all the words. I didn't know. I understood intrinsically, basically, what she was talking about. Like it really, I understood the concepts, but I did not have the words to articulate my practice. And oftentimes now when I teach a class, I will ask the nurses, can you tell me the difference between nursing and medicine? And they cannot articulate it. So it is so important to know the words, because if you can't articulate what you are and who you are and what you bring to the table, nobody else is going to do it for you. So that kind of set me on a path, and the more I listened to it, the more I understood it, but it wasn't until I really started teaching it that I really understood it really well. And so when I was hit with a problem at work, we had very low patient, at the time called satisfaction scores. It's not called that anymore, and I'll talk about that. And so it was all of our units had bad nurse listening scores, so nurse listening. So I was tasked with, you need to get these nurse listening scores up, like in a month. Yeah, okay. And so I'm thinking, okay, I went to the literature, I looked, there really wasn't anything there, so I thought, well, I better go back to school, get a doctorate, and this is what I'll study, which I did. And so what I'd learned in the past about nursing and the song and the role and what our role really was and all the things that you've seen so far today, I understood that it had to be uniquely tied with that listening can't be something that I understood, like what the behaviors were, that what am I supposed to tell the nurses to do to make their listening scores get better? I don't know, there's nothing out there. What is the patient perception? So even though I figured, okay, I'm going to learn what that means, and I did through qualitative research, what I understood at the end of the day was that it didn't matter if I knew what all those were, if it was out of context, if it was out of the clinical setting, which is why I'm putting it together. It's the listening, but it's also in the context of who cares? Who cares what those do? It's in the service of quality and safety, in the clinical setting, and understand, and how do you perform that with understanding your role and going from there. So this is my mom, the second from the left, with her cousins. This is in Ireland. My family lives in Northern Ireland in Belfast. And so she was there with them. She's 93. This is a couple of years ago, but she honestly still looks like this. Has not lost a brain cell. She's fabulous. Maria can tell you that. But a few years ago, she had a stroke. And we didn't know how devastating it was going to be. And so she did have some deficit in her speech and in her ability to write and in her ability to swallow. And when they determined it was her time to be discharged, a nurse who was working in case management at the time came into her and gave her a packet of materials. It was about nursing homes, it was about walkers, it was about all of these, aids for, ADLs. And she left. She didn't ask my mom what kind of situation she had at home. She didn't know what kind of home she lived in. She didn't know what her, did she live with anybody? She didn't ask anything. And my mother was traumatized and thinking, I need to go into a home now? I need to have a walker? No, we needed to back the truck up and say, no, not at all. And so what this nurse didn't do was listen. And so listening is so much more than hearing words. She didn't, as Dr. O'Rourke was talking about, she didn't read the room. She didn't even try to find out where the conversation should go. She just handed her documentation. And so that spoke to me, even more about listening and how it is more than words between two people. And there's so much nonverbal, but how it can absolutely impact their safety and the quality of the care. Because at the end of the day, it's not just about the stability in her physical condition, but it was about the stability of her mental condition too. That's all part of it. So, I did have a little chatty chat with, the nurse and her manager. So, about role. So, nursing's role vis-a-vis patient safety and quality. Do you think it's a moral issue? That nursing, that we bring our best selves and our role to our practice? Is it a moral issue, whether we do that or not? I believe so. So there's a quote here, which I can't really read from there, so I brought this, a quote that I really liked from Stone et al. It says, maintaining a safe environment reflects a level of compassion and vigilance for patient welfare that is as important as any other aspect of competent healthcare. Most important, improving the work environment may also improve the quality and safety of patient care. Do you believe that? I absolutely do. Is it an ethical issue? I'd say yes, and we can look at the ANA Code of Ethics. We've talked about that a couple times today. So provision 3 is about safety. It says the nurse promotes, advocates for, and protects the rights, health, and safety of the patient. We are bound ethically to do that. Provision 4 is about quality. The nurse has authority, accountability, and responsibility for nursing practice, makes decisions, and takes action consistent with the obligation to provide optimal patient care. This isn't optional for us. This is what we do. This is what we're mandated to do. This is what people expect from us. And, well, I'm not sure. We are the most trusted profession year after year, but I'm not sure why they trust us if they really understand that this is what we do, or they just trust us because we're maternal or whatever other word they want to put. But this is how we should show up. How about a financial issue? I think it's a financial issue. We talked about patient safety indicators. Sepsis, we want to talk about falls and the cost of all that. If we abrogate our duties and our role, we are going to be providing extra cost to the patient and the facility. And then finally, is it a legal issue? So we've talked about California, which is where I'm from too. So the California Nurse Practice Act 2725 says that it authorizes direct and indirect patient care that ensures the safety, comfort, personal hygiene, and protection of the patient. So there's so many platforms where it's mandated and understood that that's what we provide for the patient. So this is, you saw an iteration of this, which is us. That whole blue box is you. And it's every single one of us in a professional role. So again, you choose your profession, and then you choose in that to be a professional. Then you choose the profession that you want to be, and then you choose the role within that profession. So we show up as a leader, autonomous decision maker. Many nurses, and I did some research on this, don't believe they have autonomous practice. They see themselves as under the medical license, right? But all the stuff that's related to the nursing indicators are all our autonomous practice. Nobody has to write an order telling us to make sure they're safe, that they don't fall, that they don't get skin breakdown, that they don't get pneumonias, that they don't get, et cetera. You know them all. So we are autonomous, self-directed decision makers. And we also have a dependent practice. Okay, both. Well, I'm focusing a lot on transferring knowledge because that's, I studied the listening piece, but it's articulating and communicating. So I'll go into a little bit more about what that looked like. And then applying what we know to the public's best interest. We are here to do no harm to the public, right? And then as a scientist, we're basing all of our decisions on research. And I'll ask nurses, do you have a theory for what you're doing? And a lot of times they don't know what it is, but they have actually heard it and known it in school. And it could be something as easy as pain. Why are you giving pain medication? They understand the gate theory, they understand, how pain works, but they haven't really put two and two together that they're basing their actions on theory. But we do that. And hopefully, we haven't always done it on everything because, as has been said, we've borrowed from a lot of other professions. And so we're now trying to have more and more nursing, specific research to us. So y'all have heard about the To Err is Human, right, from 2010, right? And so the number, remember, it was 98,000 people were harmed, medically harmed by it's not just nursing, but by medical error. And there's been other studies since then, and there's a very well-known one from Johns Hopkins, and it said like 250,000 people, and I'm like, what? So I looked back, and I don't think the study was done well, and there's a lot of questions as to that. So really, it's probably not that many, but how many is too many? I mean, I think one is probably too many, right? So it's important. So here's just the categories of adverse events in case you're not familiar with it. But nurses, you can see drug events. Certainly, we're not responsible for it, but we're responsible to ask to make sure that they're not allergic to things or that they have an issue, and to realize if they are having something happen. Surgical and perioperative events, yes. Misadventure, kind of funny term for this, but events likely to represent medical error. Medical management, and then medical and surgical devices and other. So have anybody seen this in your practice? Have you seen misadventure? Nobody? You've never seen an error? Wow. You're lucky. I have definitely seen, medical errors. Okay, so how often is the nurse involved in preventing those is the question, and we have to be aware that that's our duty. So this is just interesting to see per year which kind of error you've had. But if you notice, I thought it was very interesting to see the age where the errors happen, the ages as they get older, the ages get higher, that you're having more error. And I don't know if they've come to a conclusion about why that is, but why do you think that might be?
Should the elder in the room speak?
You can speak.
Because we're not at the same level we were when we were 40. We have a much, balance is not always the same. It's interesting how often I grab a handrail when I never ever grabbed a handrail before. And the only reason I stop and go, oh, I can't do that, there's germs on it. You recognize it. We're different. We have decrements in our health despite the fact that, I can still do a half K, it doesn't matter. I still have issues that are different than when I was younger, and the elderly are not looked upon kindly.
I think that's very
It's
true.
not.
I've heard actually in some nursing schools where they'll have the students actually put on glasses with Vaseline on them and have them try to get around. And it's a real eye-opener to them, right? Because they are unable to see, they can't see the whiteboard, they can't tell what they're doing, they can't grab the right thing. But I think another issue here might be that they're not listened to. They may take longer to respond. It may be harder to get something out of them, or they may tell a longer story than you have time for. I've heard all of those things. So I think we need to be really cognizant of coming to each age bracket with the right tools. So anyway, To Err is Human, again, the patient and the healthcare team, the nurse is the integral part in that dynamic there between the patient and the healthcare team. So what we know as nursing is fine, but we have to communicate that to the rest of the healthcare team so there isn't error in the future. Did you realize that 85% of communication is nonverbal? And it's dependent on perception, which is why the theory that I used in my research was Imogene King's theory, because she bases it on perception. That are you familiar with her goal attainment theory, that it had the nurse and the patient and they each come to an idea of what goal they want to get to? Do you remember that from school? And but it started with perception. So what I found was that if you start with the patient perceiving that the nurse is not listening to them, the rest of the process is done. They're never going to get to the goal because they've already started with a perception of nobody's hearing me, and then they don't speak, and then they don't share, which I think, with the elderly population, that would be even more true. So our nonverbal behavior is super important. And then poor communication is the root cause of medical errors. So, to not ask, to not read the room, to not do all those things is going to lead to medical errors. But safety is absolutely linked to listening. And I found that to be true because when the research that I did didn't just look at the nurse behaviors that patients think are listening, but also how did that impact the outcomes? How did that impact them when they were still in the hospital and after discharge? What difference did it make in their lives? And there was. So have you seen this quote by Stephen Covey? Most people listen with the intent to reply, not to understand. And I don't know about you, but so some of the things that we do, we want to advise, we want to reassure, we want to judge, we interrupt, we criticize, argue, moralize, diagnose, etc. I just being honest with myself, I know I do that. I'm anxious to get on with it, so I'll interrupt to get to the part I want to know about. And it's a detriment to good communication because it requires good listening probably more than the good talking. We have the 2 ears and the 1 mouth, so maybe that was a clue for us. So maybe understanding when we come to a situation that it may not go as fast as you want, but we need to be willing to sit and listen to the whole story. So you're familiar with HCAHPS, and this I like to get straight all the time because we used to measure patient satisfaction. We don't do that anymore because it's not a real, it's not a helpful thing to measure. So satisfaction is a prospective look at what do you expect to happen and what do you expect to happen. You can give the exact same care, but your expectation does not meet yours, and so it's not really a helpful, indicator, right? So what we measure now and have done for the last, maybe 15 years or more, is we measure patient experience, which is a retrospective look at the care, which says, how often did we do what we said we were going to do? And it's a much more meaningful and objective thing to talk about. So, but one of the things, is nurse listening carefully to you, and that is tied so high with all the other scores, with whether they think highly of the hospital, with whether they think of their care. It's tied to nurse listening, even more than physician listening. So that was kind of compelling to me. So when I went to look at the literature, I got things about careful and attentive listening. So, what I found was listening in different contexts. So it would be like students in a classroom or patients with a physician in their office. There was nothing whatsoever about nursing, and there was nothing about other than these kind of generic things about what patients perceive as a nurse listening while they're sitting there in a vulnerable position, in a hospital bed with, being ill or whatever. So I see things like nodding, looking attentive. Now, I'm not sure what that means, do I need to, what do I have to do to look attentive? I don't know. They were kind of vague. And nodding, I have to say, I've had people do this like the whole time I'm talking, and I'm so distracted with that I don't think they're listening at all if they're doing this the whole time. So, take everything with a little grain of salt. Not interrupting and paraphrasing, we've learned all that with, feedback, readback, whatever. And then posing the clarifying questions. So, again, that's what we've been taught to do. But then the believing that nurses listened was completely tied with safety. So, so that was a good start, but I wanted to know really was what those listening behaviors look like. What could I actually tell my staff what to do? So I did a qualitative study. I didn't think I'd ever be doing that. There was, no literature. There was no measurement instrument. So I ended up at 15 different facilities that were representative of a lot of different systems. I had 23 in-person recorded interviews, and I was surprised they lasted from an hour to 2 hours, and they really had a lot to say. And they had been, my committee wanted them to have been recently discharged. Okay, they said they are not going to remember if you get them from a long time ago. And so that was very interesting. They'd been discharged between 4 and 180 days. And when I was speaking with them, they were some of them hearkened back to 60 years ago when they had their baby and somebody didn't listen and what actually happened to them. So the timing, they didn't necessarily remember being listened to, but I can tell you they remembered not being listened to. And they could tell me what that looked like, what that behavior was like. So anyway, they were culturally and ethnically diverse. And I did med-surg and tele, kept it to that. So it was ortho, non-ortho, medical, and neurological. So just want to make sure. Okay. So they gave me a lot to consider, and I put them into themes. So here's the behavior by themes. So the first thing they talked about was making a connection. They wanted to start the day with their nurse, the shift, by making a connection, however that was. And the eye contact, again, I have to kind of be careful about that because in some cultures that's not always appropriate. So you have to be a little culturally competent there. But attentiveness, and they pretty much all of them said, if you could just look at me before you look at the computer, just to start the day. And they all said, we know you're really busy, but we just want you to acknowledge us as a person, and then your day will be much easier and we won't call you so much, So they wanted us to stop doing other things. And I think that when we come in and we have the cows or wows or whatever we call them, and we're doing this and saying, yeah, I'm listening to you, they don't think that we are, because even if we say it, because we haven't just stopped and done that one piece at the beginning. So, and they do want personalized care, and they've said even things like, just could you put a picture that my grandchild put up on the wall, and if you acknowledge it or whatever, they just feel that they've made that connection right off the bat. But yeah, look at me, not at the computer. Once you do make that connection, they get it. They're like, it's okay, we know that you have this stuff to do, we know you have to chart. So yeah, it's good for them and it's good for us. Then putting them at ease, they said following through in timely responses. So they did understand that we can't always come at the exact time they need, but if we could tell them how long it would be, it gave them a sense that they had some knowledge and some control, and that they weren't just left, in the dark hole there. And anticipating their needs, which I do think is part of our professional role, is being prepared to understand them enough to know maybe what they're going to need and ask them about it. And then, of course, care and empathy. So those were two. And the third one, which goes with the theme of this, is ensuring the safe care. So, of course, answering and explaining. But the biggest thing here was believing them. They said so often they're not believed. They said, oh, I know my own body. I know what I've gone through. And when the healthcare team doesn't believe me, they give up, basically. And, they'll say things actually go wrong. I had a story of a guy who had a colostomy, and it was very difficult to put on, and he said, okay, I know how to do this. Let my wife come in and do it. And the nurse said, I've been a nurse for X amount of years. I know what I'm doing. And of course, she put the thing on and it fell off within the beginning of the shift. It was a night shift, so then they couldn't call the wife to come in and put it. It's this kind of thing that had you listened to me, this would not have happened. And so then they start losing trust, okay? So assuring the smooth transitions, and that kind of goes to the other HCAHPS score about, transition of care, which is often low because they don't see us talking to each other. So they like that. The next one was taking direction from the patient, like this, putting on this colostomy bag. They want to be part of their own care. Not everybody, but the ones I spoke to actually did. They wanted assistance when they needed it and asked for it. And they wanted us to notice the cues that they were giving. Sometimes they didn't feel able to or willing to articulate, and so again, it's with nonverbal stuff. Did we notice that they were having a really hard time getting up and maybe needed help, or that they were hesitant about talking when somebody was in the room? There's just any number of scenarios that you can think of where they want us to be attentive to that. And they wanted us to take nothing for granted. So that's a pretty big order. But I like this IHI quote, "A lack of productive communication between patients and caregivers contributes to ineffective or inappropriate care, even to fatal errors." We can't afford to do that, and ethically and morally we can't do that. We can't be a party to that. So I also asked them about non-listening behaviors. They honestly had a hard time telling me what the nurse listening looked like, but they could easily tell me what non-listening looked like because it affected them profoundly, both in the hospital and beyond the hospital. So not believing the patient. I put this under arrogance. You don't believe them, I know better than you. Dismissing the patient's concerns as unwarranted. You can probably think back to situations that you've had with patients where they do come with a concern. I mean, sometimes it's even something like, my dog is at home alone and nobody's feeding it, or how is this, I'm missing my granddaughter's, school play or something. These things matter because even though they're not directly tied to the physical aspects of what you're there to do, they're tied to the overall, mental and spiritual and, everything, their well-being. So. Then the abuse of power, the rejecting the patient input. They want to participate in their care, but to say, what you do at home is what you do at home, but it's not what we need to do here. So I took care of a very, very famous baseball player who's one of my idols. He was a Brooklyn Dodger, and then he was a Los Angeles Dodger. And he was a quadriplegic, and he had been for a long time, and he came in often, and he was old for a quad from that era, from the 50s. And he had a huge pressure ulcer on his coccyx, and it was never ending. They had grafted it, they'd done everything. But his wife at home used like Clorox and some, cleaning products on it. And, yes. And so they came in the hospital, and that was their expectation of what was going to happen in the hospital. So to dismiss them and tell them they're crazy, you're not going to get anything from them in cooperation-wise, or you're not going to change the care for when they go home if you dismiss them as being crackpots or whatever, or make them feel unworthy. So we had to deal with that over time and give her some better tools to work with for him. So, and then arguing with the patient, if you can believe it, patients told me that nurses would argue with them, not just only from what they did at home, but also what their goal was and where they wanted to go. And then not trying to understand. It's like, okay, I asked you about this, and I'm telling you, but you're not really wanting to understand what I'm saying here. So. Two more themes here, incivility and insensitivity. The lack of eye contact, so again, it may be good, it may not be, but rolling eyes. So they had there's several scenarios where what the nurse said, they looked over and they could see the nurse rolling their eyes at somebody else. And again, focusing elsewhere, the computer, insensitive to how they felt. And finally, talking about professional role responsibilities, the abrogation of those duties was no follow-through. They've given us something that they need, and if we don't follow through, they find that to be their primary lack of trust with nursing after that. A lack of presence and awareness and not assessing patient readiness. And that's what happened to my mom. They didn't assess her readiness for not just for going home, but for learning. So I had several of them tell me, they came in, they gave me all the discharge information, but I wasn't ready to hear it. So I just said, okay. I took the stuff, I went home and I read it at my own leisure. When there was no one there to explain it to me because they were not ready to hear it. So patient readiness, definitely important. And so I have this, I don't think I'll show it right now, I don't have time, but I'm a Seinfeld fan. Anybody else watch Seinfeld? Thank you. Did you ever see the one with Eileen and going from doctor to doctor because she was labeled as difficult? She was labeled a difficult patient. So every doctor in the city had her chart, and as soon as they knew it was her, they'd say, oh, okay, it's you, and then they would dismiss her. And she's like, no, don't look at my chart, please, I'm not difficult. Patients said that to me. They didn't want to be labeled as difficult. And so they were afraid to speak up, and they were afraid to ask for things because they didn't want to be that person. So we cannot put them in that spot. So the outcomes of not listening, and this is the important part. So what? Okay, well, the patients felt vulnerable. They lost trust in us as people in the hospitals we were representing and in nursing as a profession. They lost confidence. And I had actually RNs in my study who were quite capable of saying what they needed. However, they were afraid of what was going to happen. Say it was a night shift and they didn't trust the nurse. They didn't go to sleep because they didn't want something to happen to them. So, that impacted them. Then they were lack of sleep, and then it extended their stays in some cases. They questioned their care. They felt fearful and insecure. So that's, vulnerability, but mental and physical harm they actually did. Some had exacerbation of their symptoms. And if we're there to do no harm, we've talked about that. Humiliation. They felt that they were dismissed, and one guy said to me that he didn't even want to participate in the program and the plan of care when he went home. He just wanted to forget it, yeah. And then the other thing, and the nurses even said this that were in my study, the acquiescence against their better judgment, they just did what the nurse was telling them to do, even though their better judgment said not to, because it was just easier than fighting the fight. So that put them in a bad spot. And then their feelings of abandonment, they felt anger and they felt resentment. And you should be leaving the hospital feeling anything but that. And the reason they didn't want to go to sleep is they felt the need to be their own advocate, like all night long. And then the treatment was actually ineffective because they weren't on board with it and they weren't following it. So the outcomes from the literature was increased satisfaction, which we know to be the not satisfaction anymore, but nursing, what? The experience instead of the satisfaction. They had improved emotional health. They had better functional and physical status, increased pain control, and then a positive change in their mental, emotional, and physical health, and then a decreased patient perceived stress. So these are real and tangible outcomes that just, something as easy as listening the right way actually can bring. So the outcomes of the listening study, the sense of security, a sense of trust, a confidence in the nurse, and feeling safe. Mental and emotional well-being, they were calmer, they had improved wellness and attitude, they had a feeling that they mattered as a person, and they were more willing to collaborate with the plan of care. They had comfort and physical well-being that was they were surprised, actually, that they could feel comfortable. They didn't believe that they could in a hospital setting. And the feelings of being cared for, and they were able to make themselves comfortable once they got home. So listening, it's a learned skill, but it requires humility to adapt to begin with. You have to realize, okay, maybe I'm not the best listener. Maybe I do interrupt. Maybe I am looking for the bottom line without listening. And again, listening not just with the ears, but looking for the cues, being proactive and looking for things. And it's foundational to our professional role. How do we transfer knowledge if we haven't listened? The patient said, if you don't ask me about some things, I'm not going to volunteer it. So we miss out on some precious information that we need to actually provide the care. And it requires some empathy, ability to understand and share feelings that another person has. And the poor listening, it rejects and diminishes the person as a human being. Good listening embraces and invites existence, which just goes to the core of validating another human being. So I asked them for their do's and don'ts, give us their advice, be respectful, sit even briefly, and I did a little study with sitting, and when the nurse sat and didn't have to add on to the day while they were doing something else, the patient scores, by the way, in that one unit that I used as a pilot went up from like the first percentile to the 84th percentile in like the first month that we tried that. So studies have shown that when you sit, people think you've spent way more time with them than you actually have. And that's why some waiters and waitresses, they'll scoot down, and they'll be kind of kneeling when they talk to you, and they get bigger tips. That's known. So sit even briefly. Don't add it to your day, but do it while you're doing something else. Look at me, they said. Use self therapeutically, which I love because that's what I learned in nursing school, therapeutic use of self, right? And I don't know if they teach that anymore. Clarity before saying no to a request. They felt sometimes that nurses would just say no offhand and not figure out why they were asking for it. Repeat back what they'd said and set realistic expectations for them. Do not make excuses. Do not blame others. Do not disbelieve me, and do not talk down to me. Do not make me feel like I'm interrupting your break when I call. Ouch. So they ask to connect, be aware of the environment, listen carefully, spend a little more time, build trust by listening, and value the patient's perspective on things. So where have you heard this before? The only behavior we can change is our own. I use that with myself, with my kids, with my friends, anybody who will listen. And so I have references for all of this. And actually, if you want a list of the behaviors of the do's and don'ts and all this, I've published it. So it's in, they're in here, and I can send it to you too if you wanna get them for your own use. That's it. Thank you for listening.